All right. Hello, everyone. My name is Tess Killian, and I'm so happy to welcome you to the 6th Annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department and Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for 1 social work continuing education clock hour, 1 specific MCBAP credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay until the end to fill out our post-webinar evaluation survey. Please be sure to provide your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. I'm so pleased to introduce today's speaker, Dr. Kelly Young-Wolff. Kelly Young-Wolff, PhD, MPH, is a licensed clinical psychologist and research scientist at the Kaiser Permanente, Northern California Division of Research. She is also an adjunct associate professor in the Department of Psychiatry at the University of California, San Francisco, an adjunct lecturer in medicine at Stanford University School of Medicine, and professor at Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Young-Wolff's research focuses on substance abuse, focusing specifically on cannabis use among pregnant persons and the impact of changes in local, state, and national policy. Her research interests also include investigating how stress and trauma, genetic factors, and health-related policies shape disparities in the onset and course of drug and alcohol abuse, tobacco abuse, and psychiatric disorders. She is also interested in conducting research to inform the development of effective behavioral interventions for complex patients with multiple co-occurring psychiatric and addictive disorders. She is the chapter lead on an upcoming U.S. Surgeon General report related to tobacco and serves on the National Academies of Sciences, Engineering, and Medicine's Ad Hoc Committee on the Public Health Consequences of Changes in Cannabis Policy. Dr. Young-Wolff's portfolio also includes studies of intimate partner violence and adverse childhood experiences, for which the California Surgeon General invited her to be a member of the ACEs Aware Evaluation and Evidence Advisory Committee. Dr. Young-Wolff has received 4 R01 grants from the National Institute on Drug Abuse, as well as grants from the National Institute on Alcohol Abuse and Alcoholism from the California Tobacco-Related Disease Research Program. She was selected for the 2022 Young Professional Award by the Maternal and Child Health section of the American Public Health Association. Dr. Young-Wolff received her BA in Psychology and Anthropology from the University of California, Berkeley, and her MPH and doctorate in clinical psychology from the University of California. She completed her predoctoral fellowship at Yale University in the Department of Psychiatry and her postdoctoral fellowship at the Stanford Prevention Center in the Stanford School of Medicine. Before we get started, if we just advance 1 slide. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. And now it is my pleasure to introduce Dr. Kelly Young-Wolff.
All right, thank you so much. So I'm going to go ahead and try to share my screen, and I'll just say that when I do this, I'm not going to be able to see you all or the chat. So if anything comes up that I need to know, just interrupt me and let me know. So, okay, let's see. Go. And then all right, great. So I think we are all set then. Let's make sure this will advance. Yep. Okay. So thank you so much for having me here today. I am really looking forward to sharing with you today some important information about cannabis use during pregnancy. And one of the things that tells us why this is so important is this recent report by the American Heart Association that identified two specific time periods that we really need to be the most concerned about in terms of the potential negative impacts of cannabis on the brain. And these periods are exposure in utero and exposure during adolescence. And so there's really growing evidence of the potential health risks associated with using cannabis during pregnancy. And we think this might be particularly true as the strength of cannabis products increase over time. And so due to these concerns about potential health risks, the American College of Obstetricians and Gynecologists says women who are pregnant or contemplating pregnancy should be encouraged to discontinue marijuana use, and women reporting marijuana use should be counseled about concerns regarding the potential adverse health consequences of continued use during pregnancy. But surprisingly little, especially at the time that we began doing this work, was known about how are trends changing over time? What are the reasons that pregnant individuals are using cannabis? What are the specific impacts on health? And kind of most importantly, how can we talk to our pregnant patients who are using cannabis during pregnancy? So our research really set out to try to address these gaps in the literature, and we use data from Kaiser Permanente, Northern California. So if you're not familiar with us, we are a large integrated healthcare delivery system serving about 4.6 million members in the Northern California population. Our patients are diverse and representative of the Northern California population with access to care. And because we're an integrated healthcare delivery system, and we have a robust electronic health record, we're able to connect patients' visits from mental health to their primary care, to moms' visits to their children's visits. And so it provides really rich data to do research. We also have what we call our Early Start program, which has been shown to have tremendous benefits, including improved perinatal outcomes. And it provides also very fantastic data for research. So this is our perinatal substance use screening and intervention program that's directly integrated into prenatal care. We screen all of our pregnant patients for substance use at entrance to prenatal care, which often occurs around 8 to 10 weeks gestation. So we're capturing substance use during early pregnancy. We screen people both by self-reported frequency of use based on a self-administered questionnaire. And then our patients are also universally given a urine toxicology test to which they consent that also assesses substance use during pregnancy. And these are done at the same time, so that entrance to prenatal care. Our patients who are screen positive for substance use in pregnancy are provided further assessment with a licensed social worker, provided with education. And then also what's really neat about this program is that they can continue to have substance use counseling throughout pregnancy linked to their prenatal visits. And so we know that oftentimes pregnant individuals who are suffering or struggling with substance use don't want to go to specialty addiction treatment with people who are not pregnant. And so this has been really effective by bringing the intervention directly to them as part of their prenatal care experience. So this is a clinical program. It was designed to help our patients, but one of the additional benefits is that we get rich data on substance use during pregnancy to do research. And today I'm going to talk about both our quantitative electronic health record-based studies, so these large studies we do with our patients using electronic health record data, but I'm also going to tell you about some qualitative work that we did. So we conducted focus groups with 53 pregnant patients who self-reported that they were using cannabis during pregnancy either daily or weekly, and these were conducted in 2021. And the reason for this is that too often research is really conducted on or about people rather than being inclusive of the people who are being studied. And so we remedied this gap by trying to include the voices of these individuals who use cannabis as well. So I'll be kind of going back and forth between quantitative and qualitative findings. All right, so the goal of my talk is to really try to focus on understanding prenatal cannabis use in order to impact patient-clinician interactions. And so I'm hoping to tell you about what we've learned in terms of trends in prenatal cannabis use. We'll talk about why we think pregnant individuals are using cannabis. We'll go over what we know about the potential health risks, and then we'll end with a discussion of how we can talk to our pregnant patients who use cannabis based on input that we've actually received from these patients themselves. All right, so let's just jump right into what we've seen in terms of trends. When I first started doing this work, we had heard anecdotally from our clinicians that they were seeing an increase in the number of patients who were pregnant who were using cannabis. And there had been a study that came out using national self-reported data that suggested that rates of prenatal cannabis use were increasing. And so we thought, well, we can look at this using our KPNC data, and we'll have the benefit of having toxicology testing data as well as self-report. So in this study, we found that from 2009 to 2016, prenatal cannabis use increased from 4.2% to 7.1%. That's whether we looked at whatever information we had. If you self-reported using or if you had a positive toxicology, we counted you. So that's the black line that you see here. But something else that was very interesting to us was that over twice as many individuals were identified as using cannabis during pregnancy by toxicology tests compared to self-report. And so to us, this really indicated, wow, it's likely that self-reported surveys and what we've seen based on national data are probably very much underestimating the true prevalence of use. So there's a lot of reasons why pregnant individuals may not want to disclose that they've used cannabis during pregnancy. We also looked at these trends over time by age group. And what you can see here is that our adolescent pregnant patients, so those less than age 18 in blue, and those young adult patients, 18 to 24 shown in orange, have a much higher prevalence of cannabis use across all years. And while we found that the rates of prenatal cannabis use were actually increasing significantly over time for all of our age groups, the rate of increase was more quick, more rapid among our younger patients. So not only were they starting off being more likely to use, but their rates were increasing faster over time. So next, we followed up this study with another study that tried to get at whether the frequency of prenatal cannabis use is changing over time. So we know as use becomes more common and people are more accepting of prenatal cannabis use, we wanted to know whether the frequency was also increasing. And this was important to us because there's some evidence to suggest that those who use more frequently may have greater adverse outcomes. But at this point, there was really very little known about the frequency of cannabis use during pregnancy. So here again, we used a large sample of KPNC patients screened from 2009 to 2017. And what we found was that the annual relative rates of change in self-reported monthly, weekly, and daily use all increased significantly over time. So we were getting more daily users, more weekly users, more monthly users. But what stood out to us was that even though daily use, shown in the darkest blue here, was kind of the least common frequency of use, daily use was increasing more rapidly over time than monthly or weekly use. And so another way of looking at that is among pregnant individuals who said that they used cannabis in pregnancy in 2009, 14% said that they were using every single day. And by 2017, that went up to 21%. So 21% of those who used were using daily. And I can tell you that by 2021, that daily use has increased to 32%. So we know now not only are more pregnant patients using, but a larger percentage of them are using every single day, with about a third of people who use saying that they're using daily. And I think this is really important to kind of take in within the context of this increase in cannabis strength that we've been seeing during this same period. So the primary intoxicant is THC, and we know that this has tripled over the past couple of decades. So more people using daily, and the strength of the products that people are using has also increased. So all of this is, cause for concern. All right, so This study got a lot of media attention. The US Surgeon General tweeted about this study, and he also included it in his advisory about cannabis use during pregnancy and in adolescence, as people are kind of becoming more aware of the prevalence of cannabis use in pregnancy. And when we talked with our pregnant patients, we heard many stories that complemented what we were seeing in our data. So this is an example patient who said, like 5 years ago, if you smoked weed while pregnant, people would be looking at you like, you're crazy. Like, what are you doing? They're like, who sold a pregnant person some weed? Now it's like you might see a group of pregnant people just passing the blunt around like, okay, like y'all smoking, okay. All right. The next thing we were interested in understanding is, as more people are using cannabis in pregnancy, we wanted to know whether rates were increasing more rapidly among those who did not use any other substances during pregnancy. And we were interested in this because we were hearing that many pregnant individuals feel like cannabis is safe. It's safer than what their clinicians might prescribe for them, that it's natural. And we had this hypothesis that a lot of people who would not ever otherwise touch another substance during pregnancy might now be using cannabis. And this is important because it's been really challenging to understand what are the negative health effects of cannabis in pregnancy, because there's this idea that a lot of people who use cannabis are also using a lot of other substances. So it can be really hard to tease apart the specific risks due to cannabis on its own. And so we wanted to look at whether more people were only using cannabis in recent years. So here's what we found using our KPNC data from 2009 to 2018. Again, a really large sample size, over 360,000 pregnancies. And we found that the adjusted prevalence of prenatal cannabis use was rising fastest among those who only use cannabis. So this was consistent with our hypothesis, but no one had ever looked at this before. So you can see here the black line, this is the cannabis only people. These are people who did not self-report any other substance use during pregnancy and did not screen positive on a toxicology test for any other substance. That's the most common group and the group that's increasing most rapidly over time. We also found a slight increase in cannabis and use of one other substance. And we found that cannabis and 2 or more other substances was actually decreasing significantly over time. When we looked at specific combinations of substances, we found that co-use of cannabis and all other substances was going down over time, with the exception of cannabis co-use with alcohol. So cannabis and nicotine, cannabis and stimulants, and cannabis and pharmaceutical opioids together were all going down. Again, this cannabis only going up, and then cannabis and alcohol was also going up, it looks like, especially starting around in 2016. And so this is really consistent with this notion of California sober. I'm not sure how many people outside of California hear this term, but it's used to describe people who decide to quit using drugs and alcohol, with the exception of cannabis. So they're sober, they're California sober, meaning they're still using cannabis. And when we talked to our pregnant patients, we heard themes that were so consistent with our quantitative findings, with many participants saying things like, I don't do drugs, I don't take cocaine, I don't do heroin, I don't do methamphetamine. Do I smoke marijuana? Yeah, sure I do, of course. And this patient was talking about during pregnancy. Now, of course, in terms of trends, we were interested in understanding how the pandemic impacted rates of prenatal cannabis use. I myself was pregnant with my second son, who was born in July 2020. So, right in the beginning of the pandemic. And I was very curious to know how rates of cannabis changed with all of the stress of the pandemic and everything else going on. So we were able to receive a grant from NIDA to study this question specifically, and we published this research letter in JAMA in 2021. And essentially what we found is we used an interrupted time series analysis to compare the prevalence of prenatal cannabis use based on urine toxicology testing, because patients continue to have those tests even during the pandemic. And we looked at the 15 months before the pandemic compared to the first 9 months after the pandemic. And we found that there was a 25% increase in prenatal cannabis use that occurred during the early pandemic. And when we talk to our patients who used cannabis during pregnancy in those focus groups, many of them said, yes, the pandemic definitely increased prenatal cannabis use. So this patient says, I think the pandemic does increase the use of cannabis during pregnancy. People are very anxious and going stir crazy, stuck in the house, and then finding out, oh, I'm pregnant, and all these things I would have wanted to do during pregnancy, I can't do. So becoming a coping mechanism. And I think, clinically speaking, these findings highlight what many of us already know, which is just the importance of connecting pregnant patients with resources for mental health, especially during time periods of stress like a pandemic. So. All right, so we've touched on this a little bit, but I'd like to dive into why we think pregnant individuals might be using cannabis. And I want to start by just saying that pregnant people want information about prenatal cannabis. They're looking for answers. Many who use cannabis believe that there's little to no harm to their baby. They're not trying to hurt their children. They just don't have the information. And some initial qualitative studies suggest that clinicians often have limited information about the harms, and that when patients ask them for help, they often offer little or no response to patients' disclosures of prenatal cannabis use, or sometimes they may focus solely on potential legal consequences rather than providing the health information that patients are requesting. And so this leads patients to turn online, social media, to ask friends and family, to go to online community forums, and they often receive really incomplete or inaccurate information, suggesting that cannabis use during pregnancy is safe and effective for treating pregnancy-related symptoms. So if anyone on this call has been pregnant before, you probably know the What to Expect website. This is sort of the go-to website for everything pregnancy related. And as part of that, there's this Ganja Mamas group, which is a sub-forum within this, where patients or individuals who are pregnant who are using cannabis can connect with one another. And oftentimes these conversations are individuals who are seeking advice about the safety of use during pregnancy and breastfeeding. A lot of people talking about why they're using, and we see a lot of reasons for using for nausea or anxiety or depression or relaxation, using because they feel like, they've been on an antidepressant for a long time and they're scared about the effects of that, so they're going to use cannabis instead. And then also some talking about concerns about drug testing and legal consequences. So there's a lot of people who are on that saying, this is the phone number for my hospital. Can someone else call and find out if they're going to drug test me or when they're going to drug test me? And this is an example of a thread within that forum, just to give you a sense of the kinds of information that patients are getting there. This is called Moms That Used Their Whole Pregnancy. And this one mom says, just wondering how many of you used cannabis your whole pregnancy up until labor? How did it go? Was your baby healthy? And another mom responds, I smoked every day, pretty much all day, up until hours before I gave birth. My son is perfectly healthy, gaining weight great, eats great, exclusively breastfed, and has no problems at all. He's 15 days old today. And then a different mom responds and says, oh, how beautiful. Thank you for posting. It makes me feel better about my choice to use cannabis as well. Baby girl kicks and dances and is growing healthier every day. And I like to show this because I think it highlights that these individuals are concerned about the health of their baby. They're wanting to make the right choices, and they're really feeling that cannabis use during pregnancy is safe. I think the exclusively breastfed part is interesting, given how much pressure there is to exclusively breastfeed, and that's something that's really healthy for your baby. So it shows they're trying to do all of these things that they think are going to be healthy. But unfortunately, right, there could be a lot of potential negative effects of the cannabis use during pregnancy that would not be evident at 15 days old. So this is another way where people could be spreading misinformation. And then I just wanted to show this other example. This is Blunt Blowin' Mama. She's wearing a sweatshirt that says moms who smoke weed are not bad moms. And it's a parenting podcast related to parenting and being a mom and cannabis use. And you can find articles like the best cannabis products for pregnancy and how to use them, a resource for anyone considering using cannabis during pregnancy and doesn't know where to start. So a lot of information coming to pregnant individuals, sort of bombarding them with this idea that cannabis use is safe. So it's within this setting that we said, well, gosh, we're seeing all of this stuff, but we don't really have a lot of data about why patients or pregnant individuals are using. And so as part of our research study, we wanted to try to understand this question using data from our large electronic health record. So this is one of the first studies that we did to try to look at correlates of prenatal cannabis use. And we had heard anecdotally, again, learning a lot from our clinicians, we work very closely with them. We had heard that they're seeing patients who are reporting using cannabis during pregnancy as a way to self-medicate their morning sickness or their nausea and vomiting in pregnancy. And we know that cannabis has antiemetic properties, it can help with nausea. And there was just a few qualitative studies at this time suggesting that this may be a reason that people are using cannabis in pregnancy, but there had been no prior epidemiologic studies. And so we said, well, we can do this with our data, and we conducted a series of studies that looked at this question. And essentially, using, again, a large data set from KPNC, patients screened in the first trimester, which is when morning sickness is usually the worst. And we combined data from 2009 to 2016. And descriptively, we found that prenatal cannabis use was more common in those who had a diagnosis of severe or mild nausea vomiting in pregnancy compared to no nausea vomiting in pregnancy. And results from our logistic regression analyses after we controlled for a large number of covariates found that women who had severe nausea vomiting in pregnancy had nearly 4 times greater odds of using cannabis during pregnancy, and those with mild nausea vomiting in pregnancy had over 2 times greater odds of using cannabis during pregnancy. So here is a quote from a patient. We heard in our focus group so many people talking about using cannabis for this reason. So this patient says, I had really bad nausea, so they had prescribed everything, and they kept escalating until I got to Zofran. They said, there's all these possible scary side effects. And I was like, yeah, I think I'll just start smoking again because that seems less scary. And another patient who said, I suffered from hyperemesis this entire pregnancy. I've lost around 50 pounds in the first trimester, and cannabis was the only thing that could make sure that I could eat and take my prenatal vitamins. So clinically, the takeaway from these studies, I think, is that it is likely that many pregnant individuals are using cannabis as a way to try to treat or self-medicate their morning sickness symptoms. And so for these patients, we need to connect them with nausea and vomiting treatments that are recommended by clinical practice guidelines. There's a lot of things that patients can do to help try to reduce their symptoms of morning sickness. But something that I think is less discussed and less understood is that nausea is actually a symptom of cannabis withdrawal. And so what we also think is that for some pregnant individuals who were using cannabis very heavily before pregnancy, and then they get pregnant and they try to quit or they try to cut down on their use, they may experience cannabis withdrawal. And one of the symptoms of cannabis withdrawal is nausea. And so it's very possible that for some of our patients, if they would just abstain from cannabis for a week or two, that those symptoms that they're thinking are morning sickness might actually go away. So this is something that I think is really important and could be discussed more, because if you're experiencing cannabis withdrawal and that's causing you nausea, of course using cannabis is going to make that nausea go away. And so it makes sense, but if they can just hold off from using, those symptoms may go away on their own. All right, so next we were curious to know whether prenatal cannabis use was more common in those with depression and anxiety and trauma diagnoses, especially given what we were seeing qualitatively with pregnant people reporting that they were using cannabis as a way to treat these symptoms. So this is what we were expecting to find, but there had been no epidemiologic studies done until we did this one. This was published in JAMA Network Open in 2020. So we combined data from 2012 to 2017, and what we found was that compared to pregnant individuals who did not have a depressive or anxiety disorder during pregnancy, those with an anxiety disorder, a depressive disorder, or both of these disorders were significantly more likely to use cannabis in pregnancy. We found similar results for depression symptoms. So actually, the adjusted odds of prenatal cannabis use increased significantly as the severity of depression symptoms increased. And we also found that those with a trauma diagnosis and those with self-reported intimate partner violence were significantly more likely to use cannabis during pregnancy. When we talked with our patients, again, nearly as common as hearing from them that they were using for morning sickness, so many of them said they were trying to use as a way to cope with mental health symptoms. So this patient says, I've had depression and anxiety issues, I've been on medication, I've tried therapy, and nothing has worked for me. So I think marijuana has always been a good coping mechanism. And when we take these studies together clinically, what this means to me is that many people are likely trying to self-medicate their mental health symptoms in pregnancy with cannabis. And so for those patients, if we can do early screening for prenatal depression, anxiety, intimate partner violence, all of these things, and better connect patients with resources for these symptoms early, we may be actually able to mitigate the risk of prenatal cannabis use. So they may be less likely to turn to cannabis use as a way to cope. However, this study was cross-sectional, and so we do need additional research to really try to tease apart the direction of these associations, because it's also possible that cannabis use could cause or worsen mental health symptoms and problems during pregnancy. All right. Another question that we had was whether pregnant people are using cannabis during pregnancy because it's legal. So California legalized medical cannabis. We were the first state in 1996. And then we legalized adult use of recreational cannabis in 2016 and allowed retailers to open beginning January 1st, 2018. So we conducted a focus group study with pregnant patients who said they used cannabis during pregnancy to hear from them what they thought about whether legalization has impacted prenatal cannabis use. And three major themes came out of this work. The first theme was that our pregnant patients who used cannabis during pregnancy believe very strongly that legalization has led to an increase in prenatal cannabis use. And they thought that this was due to easier access to cannabis, just the retail availability, having stores all over the place. They talked about the convenience and the discretion of delivery. So even though some pregnant patients were totally comfortable walking into a cannabis retailer, visibly pregnant, and buying something, others said, they weren't comfortable with that, and they really appreciated that they could have it delivered right to their door. And then they also talked about the widespread marketing and advertising and how this could make it particularly challenging to quit using. So one patient said, you look at the cannabis clubs on the corners, that it's literally like a liquor store here. The easy access, the convenience. And another said, I get text messages from one of the dispensaries that I go to almost every day of their deal of the day, and I always get pissed off. I'm like, screw you, I can't use cannabis. And she was trying to stay off of cannabis during her pregnancy, and she was talking about how these text messages were making it really hard. The next theme was around increased acceptance. So we heard from our participants that because cannabis is legal, there's actually a lot less stigma around prenatal cannabis use or use during pregnancy. It's more common, it's more understood, more people are doing it, it's just generally more accepted. And one kind of unintended benefit of legalization was that our patients said that they were now more willing to talk with their clinicians about their prenatal cannabis use. So they were more willing to have those conversations because they felt maybe like it was less wrong, or they would have fewer consequences and just more open to talk to their clinicians. This patient says, I think that if it wasn't legal and I didn't feel comfortable speaking about it in the beginning with my doctor, I may still be smoking, because if I didn't say anything, didn't have those conversations with my doctor, I probably would have just kept doing it. And something I want to say about this theme in particular is that we are doing this work in California where prenatal substance use is not considered to be child abuse. There are not punitive consequences for it. It's not criminalized. And in fact, you cannot make a report to Child Protective Services for prenatal cannabis use on the basis of a positive toxicology test on its own. So there has to be other things going on that make you concerned. And so it's for this reason, I think, that we are able in Kaiser Permanente in Northern California to screen all of our pregnant patients for substance use with a toxicology test. And in fact, we would not recommend doing that in places that have punitive policies. And something else that this made us realize in doing these focus groups is that a lot of patients equate having cannabis be legal for adult use or recreational use with there being no consequences related to use during pregnancy. And so that is not always true. And many states that have legalized cannabis for adult use, so it's legal, still have punitive policies related to prenatal cannabis use. And so this disconnect could be really problematic potentially in other states with punitive policies if patients start to think, oh, it's legal, so it's going to be okay, I won't have a negative consequence, and then getting surprised when they start to go into some of those issues. All right, the third theme was related to trust in cannabis retailers. So our participants just really believed that products that were coming from a cannabis retailer would be safe for use during pregnancy. They thought they were much safer than, getting them off the street or wherever else they would purchase them. And they appreciated the diverse product selection. So we heard a lot about how regardless of whatever symptom you were having, there would be some product that would be able to help you specifically with that symptom. And then they also saw the retailer staff or bud tenders as really knowledgeable, caring, and non-judgmental. And in fact, they talked about how, while they didn't always feel like their clinicians listened to them, and that sometimes their clinicians judged them, that these bud tenders were just so non-judgmental and wonderful and had a lot of characteristics that they wanted in their doctor. So this patient said, if you walk in there pregnant, they're not going to be like, oh, you shouldn't do it. They'll show you what will be best for you during your pregnancy, depending on your symptoms. And another said, they care about you. It's kind of like the doctor. And I'm bringing this quote up in particular because many of our participants equated bud tenders to doctors, with some believing that they received medical training or at least some training, when in fact, in California, there is currently no required training whatsoever for individuals to work at a cannabis retailer. And I think this trust that pregnant patients have in the advice that these bud tenders or cannabis retailer staff would give them is really concerning, because there is some evidence that they may actually be promoting cannabis as safe for use during pregnancy. So I want to share this study. It was done back in 2018 by Dixon and colleagues in Colorado, and it was a very interesting design. So they had a research assistant call a bunch of cannabis retailers in Colorado saying she was pregnant and suffering from morning sickness. What should she do? And in this study, 69% of the retailers recommended using cannabis to treat the morning sickness. 31% of them said, yep, safe, totally safe for use during pregnancy. And only 3% of them suggested that the person talk with their doctor without being prompted. So this was pretty alarming to us. The next thing we wanted to know related to cannabis legalization was whether pregnant individuals who lived closer to a cannabis retailer or in an area with a greater density of retailers would be more likely to use cannabis during pregnancy. And so this was a paper we published in 2021. We looked in 2018. So again, this is the first year following adult use legalization that retailers could open. And we looked at our pregnant patients. We geocoded their addresses of their home and then all of the addresses of the cannabis retailers in the Northern California region. And we found that our patients had a median of a 12.5-minute drive to the closest cannabis retailer and about 2 retailers on average within a 15-minute drive of their home. And when we related these things, so the distance and the density of the cannabis retailers to prenatal cannabis use, we had some interesting findings. So at the top half of this is proximity. This is looking at the drive time to the nearest retailer. And the bottom half is looking at density, or the number of retailers within a 15-minute drive. And essentially, we found what we hypothesized, which is that having to drive longer to the nearest retailer was associated with lower odds of cannabis use. So the longer you have to drive to get to the nearest retailer, less likely you were to use. And then we also found that having a greater number of retailers within a 15-minute drive of your home was associated with significantly greater odds of prenatal cannabis use. All right, so just to end thinking about this, right? So this is a cross-sectional study, and it might be that really truly being closer to cannabis retailers makes it more likely that pregnant individuals will use cannabis. It could be the advertising, the signs, just the convenience. But because it's cross-sectional, we don't fully understand the direction of effect. And it might be that cannabis retailers are more likely to open up in places where communities are already more receptive to cannabis, and maybe rates of prenatal cannabis were already higher. And so we need longitudinal studies to try to tease those things apart. And we have a study that's under review right now that's looking at the impact of state legalization in California in 2018 when retailers opened. And we find that there is an increase in prenatal cannabis use following state legalization. But when we further differentiate patients who live in a jurisdiction that allows cannabis retailers versus bans them, we find that the increase is only seen in patients living in jurisdictions that allow the cannabis retailers. And so that paper should hopefully be coming out soon and kind of gets a little bit more at the potential causal impact. All right, shifting gears to talk about what we know about the health risks. So just briefly, we think that cannabis could be harmful to the developing brain because it disrupts the developing endocannabinoid system, which plays a critical role in shaping brain development from conception all the way into adulthood. And this involves neural circuits that are involved in learning and memory, decision-making, and emotion regulation. And there have been enough studies now, including meta-analyses, to indicate that prenatal cannabis use is associated with significantly increased risk of low birth weight, small for gestational age, preterm birth, and neonatal intensive care unit admission. There is also some evidence that it's associated with greater risk of attention and externalizing problems in childhood for the offspring who was exposed in utero, and really less evidence for an association with other behavioral and cognitive outcomes. So I'll show data from the Adolescent Brain and Cognitive Development Study, which is the largest long-term study of brain development and children's health in the US. I'm just pointing this one out because it's a very well done study. And what they found was that if the mom used cannabis during pregnancy after she knew she was pregnant, there was significantly increased risk of attention, social, and behavioral problems in her child all the way into early adolescence at ages 11 to 12. So this is a pretty striking finding that we're able to see this association that much later in life. But the association was not there significantly for those who had used cannabis during pregnancy but stopped when they learned they were pregnant. So I think that's important to differentiate. And even the ABCD study has limitations. So there's been these research gaps in many of the studies that have limited our understanding. So one of those things is that most studies are limited to self-reported use, and we've already talked about why this is potentially problematic. A lot of times they're having the maternal or caregiver retrospective report on cannabis use from pregnancy, 10 years earlier. They're having to go back and remember what they did. A lot of times they don't adequately account for co-occurring other substance use in pregnancy, and we've already talked about how that's really important so that you can know what adverse effects are specific to the cannabis versus due to other substances. Very few have looked at frequency of use. I don't know any that have looked at whether the harms differ based on mode of administration, which we'll talk about in a minute, and oftentimes have smaller samples with older data. And the reason that older data are important is that we know that the strength of products have increased over time. So we really want to understand more accurately how the current products are associated with different risks. So we've published talking about how we need better data on these topics. And we were fortunate to receive 2 large grants from the National Institute on Drug Abuse to try to look at the health risks of prenatal cannabis use using our KPNC data to try to address some of these research gaps. So I'll share with you one study we just published last year. It was published in the American Journal of Obstetrics and Gynecology. We used a very large sample of babies from January 1st, 2011 to July 31st, 2020. And these all had their moms screened for cannabis use by self-report and toxicology testing during early pregnancy. We found 6.2% of the neonates were exposed to cannabis in utero. And there was an association between prenatal cannabis use and increased odds of having a low birth weight baby, small for gestational age, preterm birth, and neonatal intensive care unit admission. So this was consistent with what other studies have found, but this is using a much larger data set. We looked at people by toxicology testing, we looked by self-report. Basically, whatever we did, the results were robust. So we continued to find these associations. And we even did a sensitivity analysis where not only did we adjust for other substance use, but we actually did a sensitivity analysis where we removed patients who had any evidence of other substance use and looked at the subgroup that were positive only for cannabis, and we still found similar findings. So it suggests that the results were not due to co-occurring substance use. When we looked at frequency of use, we also found greater odds of low birth weight and small for gestational age with increasing frequency of use. So you can see the blue dots here that the odds of these negative outcomes go up as the frequency of use increases. And one thing I want to say is that, you know, in the 2017 National Academy of Medicine report, they found that the one association that they put in that report was that prenatal cannabis use was associated significantly with lower birth weight. And so it does seem like that information has gone out there. People tend to know that, but a lot of our pregnant patients think that lower birth weight is a good thing. They don't know the literature. They don't know that that's a risk factor for lots of other things. And so they say, oh, well, that will make an easier delivery. If that's the only thing that's bad, no problem. And so I think it's important to provide education about some of these other adverse outcomes as well. Okay, so this is just a slide talking about how our work overcame a lot of the limitations of other studies. Next steps for our research, we'll be continuing to look at a bunch of other outcomes, including fetal loss, birth defects, and then developmental delays and psychiatric conditions. As I mentioned, we don't know a lot about the risks of different modes of prenatal cannabis use, so we were able to pilot test screening our pregnant patients for modes of use. We published on those pilots, and we were able to actually get questions about mode of cannabis use implemented across the region. So now we're screening all of our pregnant patients, not just for frequency of use, but also for mode of use. This is just a quick slide to show you the modes that we're seeing among our patients. This is data from 2021. It shows among those who said they used before pregnancy, what modes they said they used in the dark blue, and then among those who said they used during pregnancy, what modes they said they used during pregnancy. And so you can see that smoking is still the most common, and use of edibles is also pretty common, and things like dabbing or the act of inhaling of vaporized cannabis concentrates seems to be less common. Topicals were less common. And we looked at smoking blunts specifically, which is a cigar that's hollowed out and filled with cannabis, because we're interested in the harms of using cannabis and tobacco together. So when we talked to our patients about modes, there was not a lot of consensus about what they thought was most harmful. One patient said, we don't know the risks between all of them. Could one be worse than another? Sure, I mean, definitely, but we just don't know. And in general, they wanted to use modes that they thought were safe and convenient and effective. So we have a new large study where we're going to be able to use the data that we're collecting on modes to look at how modes of prenatal cannabis use relate to other substance use in pregnancy, maternal mental health and physical conditions, and then also local policy and cannabis retailers. All right, so finally, I'm going to try to breeze through this. We want to end with some recommendations about how you can talk to your patients about cannabis use during pregnancy. And as many of you know, pregnancy provides this really unique opportunity to provide care to patients who might not otherwise see a clinician. And pregnant individuals are generally really motivated to improve their health behaviors for the benefit of their baby. So this was a study done by a postdoctoral fellow working with me, Tara Foti. We talked to patients who use cannabis during pregnancy to hear from them what they would like in these conversations. And we came up with some recommendations. So the first is to ask them about their use. Be curious. They had reasons for using, try to understand them. And this patient says, teach doctors how to bring cannabis up in a way that isn't judgmental, just an open, confidential conversation with your doctor. There's no judgment here. They want you to listen, really hear why they're using rather than just saying, don't use, all use is bad. First, hear them out. So this patient said, I want to explain to my doctor what the cannabis benefits are and why I prefer it over prescriptions that she wants to give me for my pain. Have a dialogue. Make it a real conversation and not a lecture. This patient said, my doctor asked a lot of questions and listened and made me feel very comfortable. And acknowledge your patient's perspective. So reflect back to them that you've heard why they're using and acknowledging their perspective. This patient said, know that whatever choices I make, I use cannabis because I believe it's the best choice for myself. And we heard from so many patients that as soon as their clinician just says, all use is bad, there's no benefits, just don't use, they stop listening. And they just say either I'm not going to come back to this person or I'm going to lie about my use because it's not consistent with their experience. But if you can do these first 4 steps, then it really opens the door for them hearing you when you go on to these next really important steps, including providing education, especially if you can do it in a non-judgmental way. This patient said, give me the health benefits of it and the cons of it so I can make an informed decision on my own. And then finally, recommend quitting. And if the patient's not willing to quit, consider providing alternatives. So you can suggest that they use less frequently, use modes that don't include tobacco, potentially switch to non-smoked products. And then if they are able to cut down or quit, to really support and praise them. And this patient said, having somebody to be like, I'm really proud of you, we're cheering for you, that made me feel good. Okay, so that's a lot, I know, and I want to leave time for questions. So I'm just going to end by trying to remind everyone that pregnant patients really want to make informed and safe choices about prenatal cannabis use. They're doing the best they can with the information that they have, but they're continually bombarded with information in the environment that's supporting this idea that cannabis is harmless. And we know enough now to very strongly recommend that pregnant individuals stop using cannabis or cut down if they're unwilling to stop completely. But we need more information as well. So one of the things I really like to do is to be able to answer the question we get all the time about whether specific modes are the most harmful compared to other ones. So we do still have work to do around like whether the strength of the product matters and things like that. But I think the bottom line is that in order to get this information that we know already to our patients, clinicians really need to educate themselves and then listen to their patients in a curious and non-judgmental manner so that their patients will then be open to this really important information that they have to give. So I just want to acknowledge all of the collaborators on this work and our funding sources, and I think we have time for a few questions. So thank you so much.
Thank you so much, Dr. Young-Wolff. That was a great presentation full of lots of data, and loved hearing perspectives directly from the people you were working with. Before we jump into Q&A, I do have a few reminders that I want to share with our attendees. First, we do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And while you submit your questions, just some reminders, the webinar recording and the presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Also, this webinar, the live webinar, has been approved for 1 social work continuing education clock hour, 1 specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out our evaluation form with your name and email address and follow the instructions that are specific to the type of credit you are requesting. The evaluation link will be shared in the chat shortly. And if for some reason you're unable to access the survey through the chat, we will also be emailing the survey link to all attendees later today. All right, let's jump over to Q&A. One question we received mentions that universal tox testing is not recommended by ASAM or ACOG. And they were hoping that you could explain why you chose to use that method in your research.
Yeah, that's a great question. I think I touched on this maybe after you asked the question, but I'll just reiterate that the reason that we can do universal toxicology testing in our healthcare system is for two reasons. One, we're in California, and so there are, you are not automatically going to be have a Child Protective Services report based on cannabis use during pregnancy alone. And so that protects our patients. And then the second reason is that we have this Early Start program, which is this award-winning program that we have something to do when someone tests positive. So it's not just sort of you test positive and now we don't know what to do. We have this whole integrated program that's meant to help people to identify their use early in pregnancy and then to help them cut down. And so I think those two things together sets us up really nicely. And again, this is part of a clinical practice. We end up using the data for research, but everything that they're doing is for the patients. So I hope that helps. And yeah, we would not recommend toxicology testing universally in other places, especially where there's punitive policies.
Yes, and I'll briefly touch on, someone had asked during your presentation if that behavior would automatically constitute a referral to Child Protective Services. And as Dr. Young-Wolff said, it varies by state. The area where she is doing this work, there is no consequences. All right, another question, or I guess more of a thought that someone wanted to share, is that in their work with parents in their classes, they the participants often say that their doctor recommended marijuana use. And this person says that they know that might not be true, but have you heard other people say similar statements?
That's a great question. I'm not surprised to hear that. I know a lot of doctors also say, oh, have a glass of wine, it's okay. So there's this idea that maybe a little bit of whatever is okay. We did not hear that from any patients in our study, but that doesn't mean that it's not happening.
Thank you. We had quite a few questions asking about the things that you're going to be researching next. Wanting to know if various strengths have different results, different modes of use. So I think our audience would definitely be interested in knowing what you learned from your studies in the future.
Yeah, great. I'll just say, it's like all of these things with cannabis are changing so rapidly. It's been hard for surveys and healthcare systems to change the questions to start including things like the strength of product, which can also be really challenging to measure, but also the modes of administration. So I hope, because our patients have the same questions and we don't have answers for them. So I really hope that we can get better data to give to patients soon.
Another person asked if there is any data on the rates of accidental suffocation of infants related to parental cannabis use.
I do not. Oh, it looks like someone maybe has an answer to that question. I have not seen anything related to that. And I think some people are starting to look at prenatal cannabis use and also risk of things like SID, sudden infant death syndrome, but I haven't seen a lot of data yet.
All right. Let's see. Another question is, did any of this research account for prenatal use of CBD marketed products? And could some of these risks of prenatal cannabis use be attributed to fungal and bacterial cross-contamination in cannabis products?
Yeah, that's a really good question. So our screening question asks about cannabis use, and it doesn't differentiate CBD versus THC, and a lot of times things have both. So it was our leaders were like, that's going too far. We're giving you the questions about modes, but we're not going to try to tease into this. We got to keep it short. So we don't know. Our toxicology tests specifically for THC. So but we have not been able to account for that in our analyses, for whether it's CBD or THC. I will say that about 99% of our patients who say they use cannabis during pregnancy also say they use during the year before pregnancy. I just want to throw that in there for you clinicians, because I think it's really unlikely that patients are starting to use cannabis for the first time when they become pregnant. I think it's mostly people who are already using. And so a lot of the education and interventions could even begin prior to conception.
All right, and unfortunately we are at time, so we won't be able to get to everyone's questions today. But again, thank you so much, Dr. Young-Wolff, for this wonderful presentation. I think you got a lot of people really thinking. So we appreciate you being here.
Great. Well, thanks so much. And thanks everyone for being here with me today. And, you know, like I said, we actually have a study coming out Monday in JAMA Internal Medicine that I wanted to present the results of, but was not really allowed to. So stay tuned for that too. And hopefully we'll have some more answers coming out to your questions. Thank you so much.
Thank you. All right, and for everyone attending today, we hope you found this webinar both informative and interesting. We would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. So please use the link in the chat to complete our feedback survey. And as a reminder, this live webinar has been approved for 1 social work credit, 1 specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out the evaluation form with your name and email address. If you're unable to access the feedback survey through the chat for some reason, the survey link will also be emailed to all webinar attendees later today. For the final presentation in our series, Dr. Leslie Lundahl will be presenting adolescent cannabis use this Friday, July 19th at noon Eastern Time. Dr. Lundahl's live presentation has also been approved for 1 social work, 1 McBAP, and 1 CME. If you have not yet registered for any of our other webinars in this series, you can do so by using the link in the chat or visiting washtenaw.org/marijuana. And we hope to see you at our next webinar. Thank you so much for your participation today.